Um, I am Mark Mendelson, the CEO of CABGU, the Canadian Associates of Ben-Gurion University. And my colleague with his handsome face is Simon Ben-Simon, who you will be handling the Q&A and the technical alliterations with the screen. Simon Ben-Simon is Executive Director of Quebec and the Ottawa region. First of all, I'd like to thank our esteemed colleagues from Israel who are joining us. Each one will be introduced in a few minutes. The format of the webinar will be, I am going to give a brief introduction about Ben-Gurion University. Then I will introduce first Professor Amir Shapiro. Then I am introducing Ofir Bustan, and then Professor Dr. Mark Clarfield. Each one will be speaking for 8 to 10 minutes. And you will see at the bottom of your screen an icon for Q&A or for comments, raise hand. You can write down your questions and Simon will be fielding them at the end of the webinar. We expect this to finish 5 to 1 o'clock the latest, and I think it will be a fascinating hour for all of us, actually a little less than an hour. So let me tell you, I am, as I said, Mark Mendelson, the Chief Executive Officer of Canadian Associates of Ben-Gurion University. We have 4 offices across Canada: Montreal, Toronto, Winnipeg, and Vancouver. Each office I have an executive director, David Burson, Zach Ostrov, Shimi Wenner, and Simon Ben-Simon. And I'm thrilled that we have outstanding lay leadership, Mitchell Olbaum as national president. And we also have outstanding colleagues who have joined us today from the American Associates of Ben-Gurion University, and my new good friend and very professional colleague, Vice President Jeff Kay, who's joining us from Ben-Gurion University. What is BGU? It happens to be the fastest growing comprehensive research university in Israel. It has 20,000 students and 4,000 staff on 3 campuses. It is at the heart of Beersheva's transformation into an innovative district where leading multinational companies, numbering over 75, have opened up research and development offices, employing over 3,000 engineers in this newly established advanced technology park. This is partly owned by Ben-Gurion University, by the city of Beersheva, and a private firm. I think the ownership equity is third, or we might even be owning half of it. BGU has been recognized not only for its excellence by the government, naming it the National Cyber Hub of Israel, but we also house the National Cyber Emergency Response Team. So whenever there is a cyber attack on any national institution or grid, our team at BGU is contacted immediately. Not only have we been mentioned the National Hub of Cyber, but also the National Autism Center of the State of Israel, because of our outstanding research being done, led by Professor Ilan Dinstein. What I urge you all to do, because I know we have so many new friends and never supporters of our university, is please go to our website and the university's website, and you will be astounded at what you read. You should also know that we have over 70 research projects being conducted as we speak, all in the field of COVID-19 and the coronavirus. So we never know what could come out of our university. Just the last thing before we start, we are also a university with a conscience. Over 1/3 of our students, which is 7,000, our total students body is 20,000, as I said, participate in one of the world's most developed community organization programs, because they volunteer in the community. We are not an ivory tower. We are part and parcel of the 250,000 population in Beersheva. Just a very interesting little fact. We produce 1/3 of Israel's engineers. And now to our webinar. I have to say that I personally know each of our 3 participants extremely well. Amir Shapiro, I met 9 years ago when he brought the first engineering commerce team to participate in a contest at Concordia University in Montreal. He is a brilliant researcher when he received his BSc, MSc, and PhD from the Technion, the Israel Institute of Technology. He currently is an associate professor and actually holds the chairship of a man from Montreal, Paul Lavanier, and he's the head of the Paul Lavanier Center of Robotics. He chairs the programs for MSc degree in mechatronics and the combined BSc program in mechanical and electrical engineering. He is part of the more than 70 research teams that are working on COVID-related projects, and his interests include locomotion of multi-limbed mechanisms in unstructured complex environments. With no further ado, I'd like to introduce Professor Shapiro. The format will be that each of our panelists will speak for 8 to 10 minutes, and then we will field questions. Amir, the floor is yours, or the TV is yours. Amir Shapiro, are you there?
Very much, Mark. It's a pleasure to be here or there. It's a pleasure to be in Montreal without having to fly there. And I want to show you, I prepared a presentation, and just let me share it with you in a second. Just a second, a little technical difficulty, and okay, do you see the presentation?
Yeah.
All right, so I'm heading the Robotics and Control Lab. You see here a little bit of what we are doing, different kind of robotics. But when we started to have the problem of the coronavirus here, we thought what we can do to help the country, the world, in our fight against the coronavirus. So a little bit over after the whole country was closed on March 14. And so on March 19th, we set a meeting, Chagai Balshai, the CEO of RoboTiCan, and me, set a meeting with Yarden Nevo, which is the deputy manager of Soroka Hospital. And we asked how could we help him with the newly established Corona department, Corona unit in the Soroka Hospital. And in this meeting, 4 things came up, 4 subjects that we can do. And one is a telepresence robot that allows the doctor to actually walk around and communicate with patients. But this Ofir will elaborate on this later, so I won't talk about this. The other 3 subjects are, first is automation of the virology lab. And so we wanted to have to be able to conduct more COVID-19 tests in a specific time. This is the second subject. The third is a simulation of the virus spread in the population. And the fourth thing is about the lack of enough ventilation machines. So if we could do some self-made ventilation machines, and I'll show a little bit what we've done on all those 3 subjects. So first, this is how the virology lab looks like. So you see the tests there. This is what she's now taking. And it is covered with two plastic bags. So they have to take them from the two plastic bags and then wipe them to disinfect the test itself, then open it and then fit it to a robot that actually does the test. It's a lot of work, lots of human labor to do this work. And here is registering the name of the patient that actually did the test. So all of this takes a lot of time, a lot of human labor, and it seems to us not very efficient. So we suggested to rearrange the entire lab as a production line. As what we know from industrial engineering, that if you have a production line, then you could be much more efficient and you could do things much faster and easier. And you can introduce automation in terms of robotics in each station. So for instance, we could take out the tests out of the bags automatically with robots, not with human, and that would be much easier. And so this is what we suggested. This is the robot. Actually, you can see here at the bottom the robot that actually does the test, and we suggested to rearrange the lab as a production line, to change the packaging from plastic bags to solid packages that are easier for robots to unpack them, and to do the registering of the person name automatically, and also the extraction of the solid of the test would be done with electronic pipette and not manually as done today. This is what we suggested, and it could be, the advantage could be it will be 2.5 times faster than current situation. After the visit there in the hospital, we suggested to have some industrial engineers to rearrange the lab, and I think now is much faster and much efficient than it was before. Not all our automation stations are not there yet. We still hope that we could do this later on. The other thing is how to simulate the spread of the virus. Simulation is very good for decision making. If we want to make a decision, we want to understand in advance what would be the consequences of those decisions. So in robotics, in control, what we're doing simulation, and then we test how our decisions will affect the process later, or the situation later. So what we suggest here is to simulate how the spread of the virus is done. You see here the run of the simulation. We can input different parameters, different situations, closing of certain areas, closing of the whole countries, closing roads, and so on. And the output could be a graphic situation of the virus spread. And we suggested to build it in a modular way, distributed into regions. So you have region 1, 2, 3 here and here. And each region could be either a city or a house or a neighborhood in any kind of resolution that you want. And in every region, we have the disease model, how many people are recovered, how many are sick, how many are dead. We have infection model, how it spread inside this region. And the population, the model of the population, how many local population we have, how many arrive through traffic, how many are living through traffic, and so on. So each kind of block like this could model one house, one neighborhood, one city, or so on in
Amir,
different resolution.
Amir,
Yes?
2 minutes. 2 minutes.
All right. All right. And then we can see how changing the traffic between the regions affects the situation in each region. With this, some part of this similar simulation, the Army is already doing for decision making. Also, there is a simulation here. It's not simulation, actually, it's with robots, as you can see here. Very small robots. You see the red robots, the robots with the red lights, are sick robots. The robots with the blue light is regular robot, and here robots with green light are doctors. So when they meet each other, they randomly run around, and when they meet each other, if a sick robot meets a healthy robot, red meets blue, it changes into red. If the green, that it is the doctor, meets a red robot, then it changed back to blue. And this way, we can see how the kind of infection disease spread in the population and how many doctors we need. As you can see here, this is a simple simulations in small robots that we made. And that's it. That's what I have. One more thing, in just half a minute. We made a self-made ventilation machines. This is a group of initiative of a group of students. This is what they built with AMBO, as you can see here, and some control system for this. And this is the group of students that actually built the system for use. And that's it. That's what we've done.
Fantastic, Amir, especially the student initiative. Is that model being used at all or being produced?
No, it was produced, only one model was produced. And after that, they talked with the hospital, and the hospital said that without the regulation, without the actual testing on animals and then on humans, they won't allow it to be used, because it's too dangerous. If there is a bug in the software or or some part is malfunction, a person could die, not breathe. So
okay. Amir,
regulation here is very important.
Very important. Thank you so much. You'll probably have questions. I know we already have a couple for you. The next, I'm going to introduce Ofir Bustan, who was a student of Amir. And as a matter of fact, I met Ofir when he was part of the team, the first team that participated in the ENGCOM competition at Concordia. He has a BA in management and an MBA from Ben-Gurion University. And he's a graduate of the CABGUs. We support the BGU team every year in the Montreal's International ENGCOM competition. He's a chief operations with experience in robotics development and manufacturing operations, and finance officer at RoboTiCan Limited, building autonomous robotic systems, products for defense, smart manufacturing, and service robotics. RoboTiCan started its way developing autonomous systems in the early 2013, and it has since developed and helping medical teams and hospitals deal with the sudden jump in demand for the treatment of COVID-19 patients. Ofir, the computer screen is yours.
Thank you, Mark. I'm very happy to be here. Here to tell you about RoboTiCan and lately what we've been doing to help with fighting the coronavirus here in Israel and in Beersheba, especially. Gonna up the presentation and we could start talking. Let's see. Can you see the presentation?
Yep.
Oh, that's great. Okay, so a few words about RoboTiCan. I know that Mark introduced us, but most of the people who founded most of the students who founded the RoboTiCan came from the robotics lab in Ben-Gurion University, and we have a very good relationship with the university. We try to innovate together, doing research and practical use of inventions from the university together. And lately, since the coronavirus, actually the coronavirus started to spread in Israel, and the department, the healthcare system started to get ready for the epidemic to affect the patients in Israel, and basically they were trying to prepare to the act of opening massive amounts of corona department care units. And they called us in, just like Amir mentioned before, and they basically told us what they think they need that will help them, and they asked if robotics can assist in these situations. So I'll tell you about the NurseeBot, which is the robot that we, in a flash development process, we utilized and sent into the hospitals. And initially to Soroka's hospital, and I'll tell you how this sort of happened. So basically, the doctors, as you all know, COVID-19, at the beginning of the epidemic, all the doctors really knew it's about the systems. We all done respiratory difficulty, fever, shivering, cough, diarrhea, and vomiting. And what happens to some of the patients is that basically they need to be hospitalized when their situation, when their status is degraded. And eventually, the elders especially need to assist with technical ventilation breathing machines. And some of the patients are apathic. They're really weak and their body is deteriorated and they really need assistance. The doctors, what they did the first time they found out that they're going to be opening the COVID-19 departments in the hospitals, they bought a lot of tablets and they wanted to Skype with the patients. And this was very, very good at first. And when the patients that got into the department were very young, but when the age of the patients started to when the patients got older and older, their ability to deal with tech and to engage with machines and computers was very limited. And their situation, their capability, the physical capability to use their hands to operate tablets and talk to the doctors through screen was very, very, it was inefficient. So what we did, we basically took our Komodo robot, which is a stock robot that we have and that we build here and sell. And we put on a pole and a tablet that is connected to the hospital's communication system. We basically put the robot inside. You can see there's a small video of the robot traveling through the department. Basically, it's 4 wheels with a computer inside and a tablet on top. It's being remotely controlled manually right now. And we let the doctors use it to talk to the patients. They were very happy to do that. And then we started to think, what else can we do with that robot? And we started to talk to the doctors and see where we can help a little bit more. So what's happening right now, what's troubling the doctors is basically that the expert doctors, the most respected doctors are above the age of 60. And they're very, very afraid to get into the contaminated area of the corona or COVID-19 department. So we wanted to isolate the expert doctors that are very valuable to the system and very, very, very are a high risk group and that's a high risk group for cross infection of the COVID-19. We wanted to minimize the staff. We found out that the staff, the medical team, the nurses, the doctors, the regular doctors that are staying in the corona department are actually entering twice an hour. because first they are afraid of cross-infection. Second, the gear that they were using, they had very low amounts of protective gear, and it's very expensive, and it's basically special coats, special shoes, special covers, special N95 masks, and so forth. So they have very limited amount of the gear, and also they were very afraid. And the third thing is that it took them a lot of time to get dressed and get undressed. So they didn't really want to go in to take care of the patients every time. So they narrowed the times that they go into to twice an hour. To the contaminated area twice an hour. Also, we found out that the doctors are not the only ones, and the nurses are not the only ones that are coming into the department. It's also the maintenance stuff. They need to change the trash. They need to change the beds. Take to laundry the sheets. They need to clean and take trash out, and so forth. And as I mentioned, the elderly didn't really get along with the tablet, so they had to go in a lot of times inside just to get a medicine to a patient, or maybe a pill for a headache, or maybe just take the vital signs of inside the monitor of one of the patients inside the contaminated area. And some of the teams came in to disinfect the rooms before they were changing from one patient to another when they were changing the bed. So how our robot really helped? Basically, as I said, we had the telecommunication, allowing the doctors to work from a sterile location. This robot is very, very strong. It can carry up to 50 kilograms of any load. So the teams actually use the robot itself as a small crate that transports. So instead of getting 3 doctors, 2 doctors to maybe, I don't know, change the beds, or not doctors, but maintenance team to change bed or get the trash out, you can have only one person taking the trash, putting it on the robot, and the robot will deliver it and transport it out of the contaminated area into the safe zone. And you can send less people to take care of the department inside. So logistics and transport is another thing that we do. And we're working right now on even a better version of the NurseeBot with UVC system. That's basically using UV rays to disinfect the rooms instead of have a team coming in and disinfecting actively and physically inside the beds inside the department. So you see
Ofir,
here Professor Rosenberg.
Ofir.
Yes.
2 minutes. 2 minutes.
Okay. So I'm going to do it really fast. In here you see Dr. Rosenberg. You can see the doctors working from the main station and the robot working. I'm going to let you see how the robot works inside the department. You can see the doctor is controlling the robot. It has a microphone and headphones. You can see the robot entering into the disinfected area, at the infected area. And you can see the gear that the doctors had to work with in order to be inside the department. It's very hard to live in that, and it's very hard to function. On the right side, you can see the navigation camera. It's a wide-angle camera, and you can see that on the left side, you can see that the cameras that the patients see. This is how it looks like from the operating station. You can see one of the patients actually weeding the robot, and the robot coming to assist to one of the doctors. And the last thing that we found out, this robot can actually save some money for the hospitals as well. But the nice thing that and you can hear that from the doctors themselves. This is Dr. Eli Rosenberg, the head of the COVID department, basically in Soroka.
Ofir, don't hear.
You don't hear. So basically, this is is explaining to us how much the robot can help them and assist them. The robot visited not only Soroka, it also visited the Hadassah Hospital and Sheba Hospital, and it's being distributed in these days in these hospitals as well. We have an expert in every department, basically explaining how well and how helpful the robot is. This is Dr. Vernon from Hadassah. And I'm going to use my last few seconds to show you how the robots really assisted, and we didn't really expect it to happen. But this is a conversation with one of the family member of a deceased COVID-19 patient. He had a talk with the media, and what he told them, all he had to say is that basically the most important thing that the staff could do for him was to use the robot to let him see his deceased mother for the last time, because the COVID deceased patients currently can't really talk to their ones before they leave this world. So this robot was actually used to help and assist with that, and this is something that we're very proud of. I think this is about it.
Ofir, kol hakavod.
Yes.
This last point was very poignant, and I'm sure there are people will. Hold on, let me just start my video. People will be fascinated by it. I have to tell you, if it's not too expensive, I'd like to order one for my house. It could do some good stuff, but it's kol hakavod to you and your team. Okay, we're right on track. We're at time. As a matter of fact, we've had a couple of more people joining us. It is my pleasure to introduce Mark Clarfield. Where's Mark? Mark. He should be on. There he is. Unmute him.
Unmuted.
Actually, I have to say that Mark Clarfield is personally responsible for my sitting here as the CEO of Canadian Associates of Ben-Gurion University, because he was.
I apologize to everybody.
He was sent on a Mossad-like mission by the former president of the university to see if he could find someone who might be somehow suitable for the position. And Mark and I have enjoyed a wonderful relationship ever since. Mark is a Torontonian, received his MD from the University of Toronto. We won't hold that against him. Go Habs, go. In specializing in family medicine, community medicine, and public health, and finally in geriatrics. But he finally saw the light, and he came to Montreal. And he joined the Faculty of Medicine at McGill University, was head of geriatrics at the Jewish General Hospital, and he was also the assistant dean of students. Oh, wow, I never knew that. 1994 to 2001, they had made Aliyah. He and his wife was also a doctor at Hadassah. He was head of the Division of Geriatrics at the Ministry of Health in Israel, after which he was appointed head of geriatrics at the Soroka Hospital, and was full professor of geriatrics at BGU in Israel, where he is now Professor Emeritus, even though he is younger than I am. From 2009 to 2019, he was head of BGU's Medical School for International Health. His research interests include Alzheimer's disease, the organization of healthcare services, and he laments the fact that none of his children have any interest in medicine. I hope they at least have his interest and skill in making music. Mark, my friend, the computer screen is all yours.
Merci beaucoup, c'est un grand plaisir d'être ici. Bonjour à mes amis à Montréal, and greetings to people outside of the La Belle Province. As you can see, I'm wearing a tie here like Mark, and when I went upstairs from dinner at 7 o'clock, past 7 o'clock, and my wife said, "Why are you wearing a tie?" I said, "Well, I'm going to speak to Canadians." She said, "Well, you're still wearing your pajama bottoms." Actually not, but it really is a great pleasure to be here. And I think that RoboTiCan was fascinating. I think its name should be called Robot Canada, or Robot Can Do, like the Can Do reactors, because it really is a can do project. So I don't have a presentation, I'm slides. I'm going to talk to you about older persons in Israel and how they're coping. So just like everywhere else in the world, this terrible virus affects older people preferentially. The good news is that it does, for the most part, almost entirely does not affect children. And I think insofar as we're struggling with this terrible disease, we should keep in mind that there is some good news, and that is that children are not getting this disease, and if they're getting it, they're not getting sick, and if they're getting sick, they're not dying from it. That's the good news. The bad news is that the disease really likes to attack old people, and it attacks them with a vengeance. We're lucky in Israel. In general, we haven't had as many deaths per capita. You have to look at it per capita compared to other countries. I'll just give you a number. The number of deaths per million citizens in Israel is around 20. Now you'll say, what does that mean? Well, in Canada, it's about 40. In the United States, it's about 80. In Italy, it's about 500. Spain is 600. So it gives you a sense that so far, we're doing pretty well in Israel. However, those people that do die tend almost exclusively to be quite old. And it interests me why that's happening and what effect that's having on the healthcare system. One of the effects, like Montreal and Toronto and other parts of the world, of those elderly people who come down with COVID and often die from it, are preferentially patients from nursing homes. Because not only are these very old patients, but they also suffer from what we in medicine call comorbidity, which just means what other diseases do you have? So if you're like me, 70 years old, a little bit more, and if the question is not just what's your age, but what other diseases do you have that will raise your risk even more? So the bad news is that as much as as a person ages, he or she is more at risk for the disease and dying. And insofar as that person has more diseases, such as diabetes or hypertension or chronic obstructive lung disease or heart disease, it makes the chance of mortality even higher. As I said, probably a third of the patients that died in Israel are from nursing homes. We haven't yet had a major epidemic. We've had a couple of nursing homes, one in particular in Beersheba, which was badly hit by COVID, and many of people became ill and many of them died. But the Ministry of Health put together a very comprehensive program to protect older persons in nursing homes, and it's a national program and it's got into gear. As you probably know, Israelis are very, very good in an emergency. We're not all that good at planning. Why do I say that? Like every other country in the world, except perhaps for Taiwan, Tokyo, Korea, Canada to a certain extent, we weren't really ready for this. And we should have been ready for it because we know that flu pandemics occur every 10 years and major ones occur every 100 years. The last one, as I'm sure you all know, was 1918-19, killed hundreds of millions of people were killed by that. We knew that another pandemic was coming. We didn't know it was COVID. We should have been prepared, and we're not alone in not being prepared. Most countries weren't. But what we're good at, and as I think you saw from the two previous speakers, the expertise that Israelis have, not only scientifically, and I was very impressed by those two presentations from the science and also social point of view, we're really good at quickly getting into gear. And I think a nice example of that is just a few days after this crisis we realized it was a crisis, the president of the university, Danny Shemovich, and Jeff Kay, who I think is on this program, got together and pulled us all together quickly for a meeting one Sunday or Monday morning. I am a doctor and I wasn't allowed to be in a room with more than 10 people, so I had to sit at the entrance and pretend I wasn't there. But we got together, and some of the programs and projects you've heard about so far are a result of that fertile and quick ability for Israelis to move. The project I'm involved in is actually related a little bit to the pad that we saw. We realized that older people under lockdown are not nearly as computer literate, as was alluded to by the previous speaker, as younger people. And so it's hard for all of us, but if you don't know how to use a cell phone, if you don't know how to use WhatsApp, if you don't know how to use Skype or Zoom, you're further restricted, and many people don't know how to do that. So we got, again, in the spirit of voluntarism, we got together a bunch of students and a group of researchers. We got a grant, and we're building a kind of program that brings volunteers together and matches them with older housebound people to be their coaches so that they can learn how to use their cell phones and learn how to use tablets. And if anybody in the audience is in that age metric and wants help, we can maybe send you one of those students one day, teach you how to use your cell phone. So that's a really interesting program. The final thing I'll say is that something really interesting is happening here, and I don't know well enough yet whether it's happening in the rest of the world, but not only am I involved with BGU work, I'm also involved at the national level. So I was asked to put together some clinical guidelines that the Israel Geriatrics Society has published about what to do in case of triage. Triage means, like in war, you have various people in front of you who are wounded in different degrees. And a triage decision is who you look after first and who you may even leave by the wayside in a military metaphor. So far, although we're planning for this in Israel, so far, knock wood, we haven't had to use any triage mechanism any different than daily life. We jumped up, we boosted our number of beds, our intensive care unit beds, boosted the number of ventilators, and so far, we're coping with the numbers. Let's hope that stays the way it is. It may not, it could go up again. We're under a pretty dense lockdown right now, and we're just beginning to be allowed out. One of the questions that was asked and that's being bandied about and that's being argued about is who should be let out first. It's my view, and this is not the subject of today, that children should go back to school right away, and that's because they don't get the disease and they don't spread it, but that's another issue. But after that issue is dealt with, young people should go back to work, people who are in vital industries, people whom the country needs to defend it, to run it, the electrical workers, the water workers, people of that nature need to go back to work. And the young people with children have to go back to work too, because they desperately need to work. The question has arisen whether or not we should hold old people. Looking at one, and Mark Mendelson, what do I mean by old? For this disease, you're old if you're over 60. You may even be old if you're over 55. You're certainly very old if you're 80, which means you're extremely susceptible, as I alluded to earlier, to becoming severely ill with COVID pneumonia and dying. So common sense would say that we should have the old people held back and wait, not come out into society so quickly for their own benefit. What surprised me was I don't know how significant the movement is, but there's certainly a lot of noise by various organizations that that do good work advocating for older people. And I've worked with these organizations and admire them. I'm having some trouble understanding their claim that holding older people back is ageism. Ageism, A-G-E-I-S-M, which is the analog of racism or anti-Semitism. And this debate, we don't have time to go into it, but it seems to be roiling the waters. It's in Haaretz today. It's on television. People are asking my opinion. People are accusing me of being ageist, which I find a little odd, having spent 40 years of my career looking after frail older people.
Mark, 2 minutes. Two
sure.
minutes.
It's like calling Martin Luther King a racist. Not that I'm Martin Luther King, but the analogy I hope you'll take. So I guess I'll leave it there, Mark, because I want to leave time for questions. Ben-Gurion University, I'm a retired professor, but it's really a very impressive place. And I think you saw before I spoke 2 wonderful examples, many, many examples of quick, wonderful, thoughtful, brilliant work that people do here in COVID. And also, let's not forget, there's a world outside of COVID. And the doctors are looking after COVID, and they're also looking after heart attacks and strokes and broken hips, like they always do. So hats off to all of them. Thank you all for coming and listening. And I'll hand the microphone back to Mark Mendelson.
Thanks, Mark. Simon, can you just put me on video? Simon?
Yes.
Okay. Mark, as always, you are illuminating, you are erudite, and you are funny. Especially the one about the wood up there, touch wood. Simon Ben-Simon will now field the questions. And please, Simon, the computer is yours. I know that we have quite a few questions.
Thank you, great. For the robotics team, how long does it take to get the NurseeBot up and running in a hospital, and what is the cost?
Well, right now we're renting it for the COVID departments for 2,500 shekels a month. It's a rental program. It took us something like 3 weeks to get 5 robots running. We're expecting to produce a lot more. If you have any more.
So a connected question to that is, how many are being used in Israel today? And a third connected question would be, would there be a plan to send them outside of Israel and New York hospitals that have been hit so hard, for example?
Well, after the pilot was finished last week in Soroka's COVID department. Right now they have one running in their department right now. We're delivering one to Hadassah next week, Hadassah Hospital, and Sheba Hospital asked for 5 more. So that's going to be probably in 2.5 weeks now. We have people contacted from Japan and from New York, actually, regarding the robots. We're still in talks with them. We hope we'll be able to ship some soon.
Thank you very much. A question for Dr. Mark. In Quebec, family members cannot go into a nursing home, and as a caregiver, in homes where care is deficient, the family member did not know how bad it was. What is happening in Israel? I think you alluded to that a little bit. Can you elaborate a little bit more?
Yeah, we haven't had any situations in Israel, such as was in Dollard or somewhere in Quebec, where they found a whole bunch of, I read about it in the paper.
On the West Island.
I'm sorry?
On the West Island of Montreal.
West Island, yeah. We haven't had any catastrophes like that. Catastrophes like that have been reported where, if you don't know what I'm referring to, where nursing homes are found with 10 dead people and the staff have left. That situation has happened in Italy and Spain, unfortunately in Quebec. I don't know about Ontario. It has not happened in Israel. It's unlikely to happen in Israel. We're a very small country and a very tight place. People know what's going on and they have telephones. But until today is, what's today? Tuesday, Wednesday, I can't even tell what day it is anymore. Until today, families were not allowed to go into nursing homes. A directive went out today, or it's meant to start today, to allow family members to go into nursing homes under very controlled conditions. A good friend of mine and a respected colleague who runs a nursing home called me up in panic. He said, since this epidemic has started, I have worked 22 out of 24 hours a day to keep my nursing home clean of COVID. And so far, thank God, there's no viruses in my nursing home. I don't want anybody other than the staff to come in. So we're in law, we're allowing them to come in, but there's a pushback from some of the nursing home directors, I think with some justification. So this is a push-pull. Every decision that we're taking, somebody wrote an article called The Hammer and the Dance. The hammer is to smash the curve down so it's flat. The dance is how to get out of it. And the question that you posed to me is one of the dances that we have to do in nursing homes.
Thank you very much. A question to, I guess, to Amir and to Ofir. How far do you expect robotics to directly interface with patients in the next 5 to 10 years?
Okay, I don't know how far, but I think at least within closed units, they could help a lot. Also in intensive care, when doctors want to see the monitors, the patient at every instance, they want to be able to walk around without going there actually. And also cancer patients, sometimes when they are going through chemotherapy, they need to be alone, to be isolated, so robots can be used for them as well. There are several tasks that robots can do in hospital, from just delivering things, up to interacting with patients, and even disinfecting rooms with UV light, ultraviolet light, for disinfections of rooms or corridors or anything else.
I can just add a quick my note that we were in RoboTiCan, we've been working for the past 5 years, getting very cool tech into a lot of places, defense, hospitals, retail, and the willingness for doctors to get robots inside the departments was very, very, it was non-existent. And since the corona, their attitude changed dramatically. So I think it's going to affect the future and kind of boost getting more robots into hospitals in the future, even after COVID-19 will pass.
Thank you. That was actually another question: is how has the virus changed the relationship towards robotics in healthcare? So thank you for that. Dr. Mark Clarfield, one of our participants is asking, is it fair to say from your experience that people who are over 70 with no comorbidities are less at risk? Is there data to support this hypothesis? Say people not taking medications, no diabetes, no heart disease, etc.
The answer, I've got good news and bad news. The good news is the flip coin of the bad news. If at any age, doesn't matter how old you are, 20, 30, 40, 50, at any age, comorbidity, diseases such as hypertension, obesity, diabetes, chronic obstructive lung disease, all of these comorbidities raise your risk at every age. Adraba, even more so in the elderly. So if you're 70 and you run 25 kilometers a day and your blood pressure is 110/70 and your cholesterol's down in your socks, you're still at much higher risk than a 60-year-old who has those same conditions. The claim by some 70 and 80-year-olds, and I understand the claim, but it's not valid, is that I'm in such great shape, I'm much healthier, I'm 70. I'm much healthier than that 60-year-old down the street who smokes and drinks. That may be the case, but you're not healthier than the 60-year-old who, like you, jogs 25 kilometers a day, has a low cholesterol, no hypertension. Age, unfortunately, is among the strongest risk factors for catching this disease, getting pneumonia, getting into ICU, and dying. That being said, most older people, even those who are 80 and 90 who get this disease, don't die from it. Something like 80% of 80-year-olds who get it survive it. But compare that to 98% of 20-year-olds. So the older you are, the worse it is. The unhealthier you are, the worse it is. If you're old and unhealthy, it's bad news. It doesn't mean you'll get it, and it doesn't mean if you get it, you'll die. This is a risk factor. Risk factor predicts disease. We all know people who smoke for 60 years and nothing happened to them. We all know people who died of lung cancer who never smoked a cigarette in their life. Look at it that way. But age is clearly a risk factor, and we can't get away from it.
Thank you. Any other questions? One more question to Ofir. We see that your company is based in Omer, in the Negev. Why did you decide to base the company in the Negev?
Basically, like I said at the beginning of my talk, that most of the people who founded the RoboTiCan was actually from Ben-Gurion University. They were originally from the center of Israel in the north, and no one was from here. But after we stayed here for 4 years or more, in the university, we really liked the area and the calm, and we think it's beautiful, and we decided to stay here. And Omer is very close to Beersheba. It's basically the same area. So we started Beersheba and moved to Omer when we wanted to build a bigger factory.
Great, thank you.
It is actually located 10 minutes drive from the university.
Thank you.
Only if you're a very slow driver.
Yes.
Simon, am I correct in assuming that we have no more questions?
Let me just check. One interesting one last question, if I may, to Mark Clarfield. Is Soroka handling the COVID situation differently than other hospitals or Hadassah, more specifically, because this questioner knows that your wife works at Hadassah?
Well, I'd say that Hadassah and Soroka are tied for the two best hospitals in the country. I know, I think the Ministry of Health, that's a good question. The Ministry, it's a small country. The Ministry of Health, we know everybody and everybody knows us. So the Ministry of Health has a pretty tight control, over what the guidelines are. And Soroka is a great hospital. It's really well run. The Director General is a very clever guy. The staff, I worked there for 20 years. The staff are top notch. The only problem Soroka has is the problem of the periphery, in that it's understaffed compared to, say, Tel Shomer and Tel Aviv or Hadassah and Jerusalem. But the staff that are there are top notch.
Thank you very much.
You're welcome.
Okay, I think this wraps it up. I have to say, how come there's an echo, by the way? I'm sorry for that. But I have to say that this is one of the most fascinating webinars that I have experienced. I thank you profusely to Professor Amir and Professor Mark and businessman par excellence, Ofir. The three of you should continue to thrive and be safe and healthy and do these outstanding things that you're doing in Israel, in medicine, in robotics. I want to thank everyone who, almost 100 people who participated today. Those of you who are not familiar with Ben-Gurion, go to our website. As was mentioned, there are over 70 research teams at BGU dealing with COVID, and we always need help in that, financial help. Please get in touch with your regional office and get involved. We need more people, great people, interesting people, and you'll see how outstanding a university we really are. Stay tuned for our next Wednesday webinar. We are just working on it, and it's a hard act to follow after Amir, Ofir, and Mark, but we will do our best. So thank you to all for joining, and Yashar Koach to all.
Thank you.
Thank you.
Thank you very much.
Thanks to everybody.
Thanks, Mark. Thank